Our second presenter is Len Finocchio, who is the Associate Director of the California Department of Healthcare Services, where he focuses on the Medi-Cal program and state implementation of the Affordable Care Act. He has been in various health policy capacities throughout his career. Prior to this job, he was a senior program officer for the California Healthcare Foundation. Did you switch? And he also held positions for Children Now and the Institute for Health Policy Solutions. Like me, he's a Go Blue guy. He got his DRPH from Michigan. I got my PhD. Paul, how many years ago? We got grade together. But Paul was the person who got me into this, and I thank you and come here out of pure devotion. And Len also received his Bachelor of Arts in Psychology from UC Davis. Something that you may want to know about him is in his spare time, and he doesn't have much, he's also on the faculty at San Francisco State where he teaches health policy. Len? Where are you?
I'm right here.
There are you. There you are.
This feels like the first day of class, which for those of you, how many of you teach? You have to do a little weeding. You don't want the ones, because their problems on the first day, their problems all semester long. So to make them think I'm a little bit nuts, I always start the class by saying, you will get your money's worth for this class, because by the end of it, your head will weigh more. So I say, go home tonight and weigh your head. Stick it on a scale. Weigh it, and at the end of the class, weigh it again, and there will be a few more ounces, because you will learn a lot from this class. They always look at me, can I really weigh my head? So, I don't think, I had never thought to ask, did anyone actually do it? But it weeds out some of the ones who think you're a little bit nuts, because the class is fairly demanding. I was thinking of a cultural reference, since so many of those were used this morning in relation to my new position, and I've been there about 8 months. How many of you have seen the United States of Terra? Which is a show on, I don't know, Showtime or something I've been watching on Netflix. It's about a mom who has multiple personality disorder. And so it's about her, what triggers switching to a different personality and how her family reacts. And I was thinking about how in this position, and my wife would probably say this, you have multiple personality disorder. Because when I'm dealing with budget issues, which I'll talk about some, it's very dreary and sobering and kind of sad and difficult. And then when it's about the Affordable Care Act and the expansion of Medi-Cal and universal care, I'm excited and everything's wonderful and all these great opportunities. Then there's the sleepless worrier about the fate of the Affordable Care Act. What's going to happen? What's the Supreme Court going to do? And then all the while kind of marathoning your way through all of this. And the last one, which is also very prevalent, is how to be a resolute steward of public resources, which at the end of the day is what Medi-Cal is about, and being a smart purchaser of services and trying to drive some improvements in the healthcare system at every opportunity. So now I'm going to go into my professorial overview and just provide a little bit about what the Medi-Cal program is. I mean, some of you will know this in detail. Many of you, Medi-Cal might be a little bit mysterious and exactly what it is we do and who we take care of. I find myself having these conversations with friends and family all the time. So we provide care. It's going to be, in the budget, it was predicted to be $8.3 million by the end of next fiscal year of the most vulnerable people in California. So what this tells you, and this will be relevant in a moment when I talk about how we try and deal with constraining Medi-Cal spending. We cover infants, kids, parents, people with disabilities, and pregnant women up to certain levels of the federal poverty level. That's where the red ends. That's what's required by federal law. California is a more generous state, so our legislature has decided that we can provide more generous benefits higher up the federal poverty level to more people. And this will become important in a moment, because when you try and restrain spending, you can dial back income eligibility until they pass the Affordable Care Act. 48% of Medi-Cal beneficiaries are kids. 25% are adults, typically moms who are parents of those kids. And then about a quarter are seniors and people with disabilities, all of whom are very poor. and 53% of whom are Latino. Benefits, comprehensive benefits, there is a list on the right side of optional services, which again is another way the state can restrain spending, is by deciding not to provide optional benefits, which we have had to do over the past couple of years, which is always, I put on this sobering, dreary hat of having to restrain spending by getting rid of benefits like dental services, which were reduced for adults a couple of years ago. Beneficiaries are kind of split between getting services through managed care plans, many of which are represented here, and about half through fee-for-service. This is a bit old. This is going to change pretty dramatically over the next few years. Whereas part of our being a good steward of public resources and thinking through delivery innovation, it's moving populations more and more into organized systems of care, including the most vulnerable seniors and persons with disabilities, and as Sandra mentioned earlier, the dually eligible. So big move to managed care. Here's where we spend most of our money. 21% goes to managed care. Hospital inpatient services, about 14%. The reason I show this often to my students is to say, when we propose reductions in spending, whichever slice of the pie is most targeted is where the most difficulty and the most challenges will come from. Numbers going up, so these are a couple of years old. Now we're at 7.5 million beneficiaries, on our way to 8.3, and spending is about 45 billion. And as I'll talk about later, as we add through the Affordable Care Act up to 3 million more beneficiaries, it'll be 1 in 3 Californians who's insured by Medi-Cal. And so from the steward of public resources, 1 in 3 lives as a Medi-Cal live, tremendous purchasing power to drive innovation. So what are we spending our time on? I'll try and provide some illustrations. Sandra laid out the big issues that we're excited about and working on right now. And I'll try and illustrate how this is actually what it looks like to actually work on this stuff from the inside. So our goal is to get to 2014, everything in place, ready, all of the provisions that are to be put in place before 2014 are in place, and we feel good about where we're at. We have, this is an inside baseball 1115 waiver, which was passed a couple of years ago, actually a year ago, which allows us to do innovations within the program. Many of those innovations look like what is required in the Affordable Care Act. Right? Moving to managed care, early expansion into Medi-Cal at the county level, and pushing care delivery system innovation and reform through different payments and moving to managed care. Starting in 2014, the income eligibility will move from, well, for childless adults, which is really who remains uninsured, up to 138% of poverty. Most of those people will be childless adults, and I have some slides at the end from UCLA to give you a picture of who that group is going to be, and it might be slightly different than you imagine. Our waiver also allows us to promote reforms within public hospitals and the California Children's Services program, right? Again, moving to our risk-sharing model and managed care. And also managed care expansion for seniors and disabilities and persons with disabilities. Let me talk a little bit about what we've been working on as far as eligibility and enrollment simplification. So for those of you who know Medi-Cal well, to enroll in Medi-Cal, you have to apply in person in a county welfare office, which can be a challenging experience. We did a bunch of, when I was at the Healthcare Foundation, a bunch of focus groups, and it was amazing to hear how clever people had become navigating that system. You know, go between 11:45 and 12:15, sit on the right side of the waiting room because those goes faster, and you want this person who's behind the counter, and then take all your make them Xerox everything for you and give you a receipt for all the documents you brought. Or don't go to the office in Oakland at all. Get on the bus, go to Pleasanton and apply there because it's a much more friendly process. So as Sandra laid out, the vision in the Affordable Care Act is to make this as user-friendly and automatic and not even in person, if at all possible. All right, so 4 ways to enroll: in person, through the web, which is where we're spending most of our time and energy, by mail and by phone with one application. So we've been working closely with Kim's colleagues and staff at the exchange and have a solicitation out there for a vendor who will create this online enrollment system for the state, which will connect with existing Medi-Cal systems, federal data hubs, so that we can verify that someone is who or she says that they are, and what their income is. And collect data so we can send it to the health plans, and keep that data so we can do research on who's eligible, how long did it take them to enroll, performance metrics for enrollment. So it's been fascinating to deal with that. So we expect 6 vendors to apply in the next couple of weeks. Let me go back to a couple more things we're also working on. So the Affordable Care Act also incentivizes prevention. So we're working on a payment methodology to incentivize the creation of health homes in managed care plans and elsewhere. Health homes, yes. And we're also working on 2 major payment reforms, going to a DRG-based system, which all of you know through Medicare very well, and also mirroring Medicare, the non-payment for healthcare acquired conditions. So if you make a bad error that's hospital-based, and there's a list of 10 or so items, Medicaid's not going to pay for it, which many of you know well through Medicare already. So then I have to put on my hat of being dreary and sober and struggling with the state budget and all of the difficult things we have to do within the Medi-Cal program because our state budget is so challenged. So there are $842 million worth of cuts for the Medi-Cal program. So we've tried to look at this not just as hacking away, but as an opportunity to drive some of our agenda around performance improvement and value-based purchasing. And as Sandra teed up, how do we incentivize the evolution of care delivery models? And I'll use one specific example. So we are proposing in our budget to move more seniors and persons with disabilities into managed care. And here's the example I wanted to share with you in more detail. To change the way we pay federally qualified health centers. How many of you from an FQHC or know how FQHCs operate? They're paid on a per visit basis, cost-based reimbursement. So our view, and what comes with that, is a lot of restrictions about how they can deliver services. There are 5 practitioners, physicians, nurse practitioners, dentists, and 2 others who have to participate in the visit in order to get paid. So our proposal is to pay, instead of fee-for-service, which encourages volume, not necessarily quality or good outcomes, but instead pay per member per month. At the same time, relieving those clinics of the restrictions within which they have to use their workforce. Right, so they can have more telehealth, use medical assistants more, use their nursing staff more, use health educators more, rather than always having to see one of those 5 practitioners in order to get billed, or in order to bill us so that we can pay them. So it's moving that really important group of safety net providers along the continuum of payment reform, along to innovation. Very challenging. As you know, change is incredibly difficult, and we're hopeful about this one. Expanding managed care into rural areas. So for all of you from health plans, we'll be excited to work with you on how to operationalize this. So we see the future very much more and more and more managed care, even in areas where it's been traditionally difficult to do. One small thing is Medi-Cal beneficiaries can change health plans every month. If they're upset, does not working for them, they can up and go to another plan, which on your end, on the health plan side, is incredibly challenging. It is for us too. So we propose to align that with the way open enrollment works for commercial plans, which is annually. And lastly, a proposal for value-based purchasing. So working with UCSF and other academic institutions to understand from an evidence basis what services aren't really worth paying for when there's an alternative which is much more effective. So one that comes up a lot is vertebroplasty, which is a lower back procedure. Many studies now show that it has very little effectiveness. So our question is, why are we paying for that when there is a better, more cost-effective alternative? So what we hope to do is systematize the way we're reviewing evidence, come up with proposals for services, not benefits, but for services that we do not want to pay for, or there's no evidence upon which we would pay for them, have a very public process to explore that with stakeholders and providers, and then make a decision. So, looking ahead. So a couple things. Who are the new Medi-Cal beneficiaries? How we think of ourselves as a purchaser. Thinking through coverage and care alignment, particularly with our partners at the exchange. And then the issue that Sandra raised, and I think Dwayne's also going to talk about, which is capacity, which also wakes us up at night. According to UCLA, 3 million new Medi-Cal beneficiaries will be eligible in 2014. Actually, it's split. About 2.13 million will be newly eligible, and there's about 900,000 who are eligible now, but not enrolled. The idea is if eligibility simplification and enrollment becomes so much easier, that these groups will enroll very quickly. So who are they? Predominantly working age, between 18 and 44. Single, childless adults, about half of them. 1 in 3 will have kids. Predominantly Latinos. And over 2/3 report excellent or good health. Which I think there was lots of concern that, geez, this is going to be an adversely selected population, and they're all going to come in very sick and very needy, and all this pent-up demand. Certainly there will be some of that. But from UCLA's research, on average, it's a fairly healthy working population. So we're always aiming to be a smarter purchaser of services, right? We face terrible budget deficits. As a steward of public resources, we're trying to do our part to bend the cost curve, value-based purchasing, promoting organized systems of care. We, again, moving beneficiaries to managed care and really focusing on how we can have better accountability within managed care plans and within FQHC clinics and all of our providers for reporting on quality, access, and outcomes. So we're spending a lot of time thinking through how we collect data, how we use data, and how we report data. Big project right now, actually with the California Healthcare Foundation, on thinking through how we can use our data in the best way possible. And spending a lot of time thinking about the integration of behavioral health services. So we are absorbing the Department of Mental Health and their beneficiaries. So we are doing an enormous behavioral health assessment to understand the prevalence of mental illness within that population, and how is it that we are going to integrate them into our managed care plans, and how to best serve them and then measure care that's being provided to them over time. And thinking a lot about and working with the exchange on how do we think about coverage and care continuity. So this is the way I explain it to my students. Think about those coming in 2014, a family who is going to have mixed eligibility status, right? So let's say it's a family about 250% of poverty, or just below. The parents will be in the exchange. The kids will be in Medi-Cal or healthy families. So from their perspective, the way they're able to choose plans, how their benefits line up, how the provider networks line up, will make their experience so much better. So how we think about qualifying health plans, collaborating with the exchange on assessing which plans are qualified health plans, which ones are also Medi-Cal plans, will make that experience for a mixed status family much, much better, particularly at the provider networks. And the ringer will be the basic health program. So there's a bill which would create the basic health program, which is an optional program within the Affordable Care Act, which takes the first tier of beneficiaries in the exchange between 138% of poverty to 200, removes them from the exchange, and creates a program called the Basic Health Program, which can have lower premiums and greater benefits than they would have received in the exchange, which is very compelling. So there's a bill that would put a basic health program, Intermister MIB, and it would allow for the continuity of care and coverage for that spectrum of income, because there's a lot of churning. In fact, Sarah Rosenbaum, who spoke earlier, did a great paper last year that there's a lot of income volatility between 138 and 200% of poverty. So they're going to move from the exchange to Medi-Cal, Medi-Cal to the exchange, exchange to Medi-Cal. So a basic health program would create kind of a cushion for them to stay in a program that has the same set of benefits as Medi-Cal, and they have continuity of care and coverage. And the issue of capacity, which keeps us all up at night. Who is going to take care of the 3 million new Medi-Cal beneficiaries in 2014, 2015, 2016? So we're thinking through how we as a purchaser can promote innovation. So again, the FQHC proposal about changing the way we pay them is not just we want to pay you differently, but how can we incentivize providing care differently and expand capacity, use physicians more, use nurse practitioners more, so they're not stuck doing visits just so that you can generate a billing. As Sandra suggested, use professionals at the top of their license, which there's many good models for, and really focusing on health homes, chronic disease management as much as possible. And I'll leave it at that, and I'm here for the rest of the afternoon. Thank you.